Greetings. It's Dan Davis coming to you from Catalina Island Medical Center, and this is March 20th, 2020. Today we're going to be talking about our testing criteria for Catalina Island and the Catalina Island Medical Center. But first I want to give you a couple of updates. A lot has changed since the last time we spoke, which was only 2 or 3 days ago at the City Council meeting. And so I do want to address some of the things that we've accomplished here at the hospital and medical center, as well as some of the things that have been going on in the United States and in the world as a whole. So first of all, the hospital has been successful in partitioning the various aspects and parts of the hospital into essentially 4 different facilities. We have the clinic on the bottom. We have the nursing home, which has essentially been walled off from the rest of the hospital to protect those particularly vulnerable parts of our population. We have the center of the hospital, which will now be functioning as a non-infectious emergency department. And then we have the traditional emergency department, which will be where we will primarily evaluate and care for patients that we think may have an infectious disease, specifically the coronavirus. We have a system of how patients are going to flow through the hospital. There will be an initial evaluation during the daytime hours by a tent right in the front of the hospital, essentially just a pop-up tent, where patients will be screened with regard to temperature and any other symptoms to make a decision as to whether the best place to evaluate them is going to be in what we're calling an infectious tent, which is probably not the best name, but that's what we're using for now. That is over on the side of the hospital where the ambulances normally drop patients off. It's a bright yellow tent. It will be cleaned after each patient, but it's where we'll do an initial evaluation with a nurse and potentially a physician and decide whether we can do the entire visit out there. We'll have a heater, we'll have something to filter air, we'll have lights, we'll have comfortable seating, etc. So it shouldn't be too much of an inconvenience. But the goal is to keep the hospital from becoming infected with coronavirus. And so as much as we can do out there, we will do. That will include potentially clinic patients who screen positive, as well as people who are coming to the emergency department primarily. Now, if someone coming to the emergency department is fairly sick, we will have to bring them into the hospital itself, and that's where we'll differentiate between the infectious part of the emergency department versus the non-infectious part of the emergency department. If we have patients who test positive for coronavirus, or we strongly suspect may have coronavirus, and they require some period of monitoring and maybe even admission to the hospital, we'll keep them in that side of the hospital in the infectious emergency department. And again, everything will be clean between patients, so we're going to decrease the likelihood of transmission. But again, we're really trying to protect our vulnerable population on the nursing home side, as well as other patients who are coming to the hospital for something completely unrelated, but certainly don't want to contract an infectious illness while they're there. So this has gone incredibly well, very smooth. The staffing is being adjusted accordingly so that we can minimize contact with staff that may have been caring for patients with infectious diseases and then coming in contact with non-infectious patients. And so I think everything has gone exceedingly well. Everyone's doing a great job, and at this point we have adequate supplies and staff to make sure that everyone's needs are met. Now, I'm sure you've been watching the news and you've seen that there are other events going on. First of all, there's been a continued increase in cases, both in the United States and around the world. Now, that's not unexpected, particularly in the United States, because as testing has become more available, we're seeing more patients screening positive, but those are potentially patients who are not as sick as the ones who were screened in the first week or two of the pandemic here in the United States. So we expect to see an increase in cases only because we're testing more. That doesn't necessarily mean that we're seeing unchecked spread, but that has to be our default assumption until we see the data level out. And depending on how testing becomes available, which we'll talk about in a little bit, we may continue to see spikes in cases as the testing becomes more and more available, or if testing does not become widespread to where anybody with a potential upper respiratory infection or a fever becomes tested, then we may not see the spike continue. So we're really, to some degree, at the mercy of the availability of testing. And I'm going to talk all about that in a little bit. We're not seeing necessarily a change in the case fatality rate, which has remained relatively low in the United States as compared to countries like Italy. And we're not exactly sure why that is. While we like to think that we provide the best medical care in the world, I'm not sure that that's the simple explanation. And I think what we see in Italy is that they became overwhelmed and that their system wasn't able to handle the volume of critically ill patients. And that at some point, patients who otherwise on another day might have survived are not surviving because of the limited resources. And that's what we're trying to avoid in the United States. And that's what's being called flattening the curve, the idea that we're going to try to keep the cases, particularly the severe cases, at a minimum and spread that out so that we never overwhelm the healthcare system. And that assures that we always have enough ventilators, that we have enough ICU beds, that we have enough personnel to take care of those patients, that we have enough personal protective equipment, that we even have enough medications. Now we'll talk a little bit about the medications that have hit the news in the last 24 to 48 hours when we talk a little bit more about testing. And so again, I want to assure you that everything is going really well at Catalina Island Medical Center. And as I said in my address to the City Council, I have some experience with disaster preparedness and work with EMS agencies, both air and ground, over town, and can say that this is by far the smoothest disaster preparedness that I have seen, and that everyone seems to be doing the right things in ensuring the health of Catalina Island and the citizens of Avalon. So now I'm going to talk to you a little bit about testing itself and our plans, at least for the near future. So one of the topics that's generated the most discussion within the United States has been the availability of testing. And at this point, I'm not sure that it's necessarily productive to figure out what went wrong or who's to blame, but we have to deal with the hand that we've been dealt. And so I want to share with you our plans and give the rationale. And I'm certainly open to comments and feedback, but this is the best that we've come up with given the limited resource that has been the ability to test for this virus. What I'd like to cover is the general purpose for testing in an epidemic or pandemic, the approach that we're proposing, at least for the near term, and then what that implies with regard to the medical center's role in the community. So why would we test for COVID-19 or coronavirus in the first place? Or perhaps I should ask, why don't we routinely test for viruses? And the simple answer is because we don't have specific treatment for very many of them. So the ones that we do have treatment for, like influenza, we have tests for. But for the dozens and dozens of viruses that come through the community each winter, we don't bother to test for them because it really doesn't serve any purpose other than helping epidemiologists figure out what viruses are going through the community and tracking them. So that brings up the first reason to test, and that's epidemiology, and I'll talk more about that in a second. The second reason to test is to give the patient, the provider, a sense of prognosis. What do they think is going to happen, and is there anything that we can do to plan accordingly? And I'll cover that too in a minute. The last reason to test, which I implied at the beginning, was because there is specific therapy. And I know that there have been some news releases about potential drugs for coronavirus. And so I'll talk about those and how we're planning to incorporate that into our decision making. So epidemiology. Again, why would we be testing for an infectious disease like coronavirus? The first is purely epidemiologic. It helps us track, and that helps us understand how it's transmitted. So when we start to see cases of diarrhea, we can figure out if that's coming from a particular restaurant, if it's coming from a water supply, or if it's being passed from person to person. In this case, We understood that the coronavirus was being transmitted from person to person through respiratory and droplets, and that is based on the initial data that we had from case to case when it was first identified in China. It also helps us anticipate the spread because we can determine how quickly it's being passed around. We can try and estimate how long the disease remains dormant, how long people are infectious, or perhaps, like in this case, how long they might be infectious even before they start to develop symptoms. The other reason to start tracking viruses with regard to epidemiology is to try to contain them. And this is where Singapore has really risen head and shoulders above the rest of the world, because they aggressively tested people and were able to sequester positive cases to keep them from spreading it through the rest of the community. And they were remarkably successful, and we may have an opportunity to do something like that here on Catalina Island, but we have to make some modifications because of the lack of available testing. So one solution is just to assume that every illness is coronavirus, is COVID-19, especially if somebody tests negative for the flu and negative for RSV, which is another virus that we can test for because there are some specific therapies available for high-risk patients. Then we can maybe assume that if it's not flu or RSV, that it at least could still be coronavirus. Up until now, we haven't seen a lot of co-infection, although as we see more and more cases, there are a few patients who do seem to have both coronavirus as well as another virus. But in general, that hasn't been the rule, and that might be the best that we can do to try to narrow it down. Unfortunately, we still are seeing cases of the flu, of influenza, here on Catalina Island, so this is particularly important for us to try to pull those cases out, offer specific treatment, and then assume that those people who are flu positive are coronavirus negative. That being said, a lot of the precautions we're taking with coronavirus are good for influenza. Still, at this point, influenza kills way more people than coronavirus has, and so we don't want our elderly and particularly vulnerable population to be exposed to influenza either. And in fact, we try to identify those patients and get them vaccinated every year just to avoid the potential complications. And even still, we see fairly significant mortality from influenza. So in some sense, what's good for coronavirus is good for other viruses as well, because it will decrease transmission throughout the community. But mostly our orientation for coronavirus has been to protect the vulnerable, because unlike other viruses or other pathogens, it seems to uniquely impact the elderly and the vulnerable, people with comorbidities, and that's the population where the mortality rates go very, very high. And you've seen that in the news over the last few days about the idea that perhaps the younger population doesn't appreciate the role that they have in protecting the vulnerable, that even if all they experience is a cold or a flu, that the most important thing is to try and avoid transmitting it to people who aren't as healthy. Now, the other potential solution is just to sequester everyone. And that's what's happened within the last 24 hours, that the decision has been made to essentially go into some sort of a lockdown mode where we keep people from leaving their houses for all but the most critical tasks. And that still will include things like going to get food and for people who are working in critical industries, continuing to go to work. And unfortunately, that then means that sometimes children have to be transported around for childcare purposes. And so it's impossible to truly sequester everyone. But that is an epidemiologic strategy that takes into account the fact that A, we can't test everyone because tests aren't widely available, but B, even if we could, we wouldn't be able to identify every case because people are transmitting the virus even before they show symptoms, or at least not symptoms that have been associated with what we understand about coronavirus thus far. And let's assume that we had enough tests to test everyone. Just because everyone on Catalina Island tested negative today doesn't mean that next week somebody wouldn't test positive, and so we would have to have not just enough tests for every person, but enough tests to test every person on a regular basis, whether that's every week, every month, or even every other day or on a daily basis. So you can see that this is a very challenging thing from an epidemiologic standpoint, because the practicality of it makes it so that we truly can't identify every case and sequester those individuals who are testing positive, particularly given the lack of testing available. Now, the second reason to test people is to give them a sense of prognosis. And one of the most common things we hear is, I just want to know. And that's understandable given that there's so much media attention placed on coronavirus for good reason. But it tends to get people anxious about their own health. And I want to assure everyone that, particularly here in the United States, that people who are otherwise young and healthy without comorbidities do exceedingly well. In fact, we think that a lot of people will have something that they don't even realize is coronavirus, and it will pass, and they'll be surprised to find out, if they were ever tested, that they actually had coronavirus. But clearly at this point, there are not enough tests to test people who just want to know. Now, what about somebody who maybe has some other extenuating circumstances? Maybe they live with somebody who is vulnerable, or maybe they have to work in an industry that won't shut down with this sequestration. So they need to know what to expect. How long are they going to be off work? How long do they need to arrange childcare? How long should they stay away from grandma because they really don't want to get grandma sick? And the problem right now is that it's taking us too long to get the results. Even if we were able to test everyone who had a legitimate reason to want to know whether the illness that they're experiencing is coronavirus, that we may not know the results for 1 or 2 weeks. So the reaction is that we just have to assume everyone's positive, especially again if their influenza test and their RSV test are negative. And that if we just assume everyone's positive, then it just becomes a question of, when is it safe to interact with grandma again? When is it safe to go back to work? And we're even having trouble being able to answer that question for healthcare workers, even in large cities at university hospitals, that healthcare workers who have an illness that looks like coronavirus and have a positive exposure to a patient with coronavirus can't necessarily get tests to figure out if that's what they have, and then figure out when it's safe to go back to work. So my hope is that as we get more availability of testing, we can expand the criteria to include people who are in a specific situation where they have a legitimate reason to want to know because of potential exposure to others in the household or because of their need to go to work. The last reason to monitor somebody with regard to prognosis has to do with monitoring patients who might get sicker and ultimately end up needing hospitalization and even ICU level of care. And that becomes a focus on those high-risk patients, and this is where we've been more aggressive here on the island in the way that we want to approach this. And I'll come back to that when we talk about the role for Catalina Island Medical Center in the community. Now, what about the idea of there being specific therapy for coronavirus and COVID-19, and that we need to know if somebody's positive to be able to offer them that therapy? At this point, there is clearly no cure. So there is not a drug like, for instance, Tamiflu and influenza, where we can actually treat the coronavirus. In the last 24 hours, we've heard a lot about hydroxychloroquine or chloroquine, a drug that's used for malaria, or it's also used for certain autoimmune diseases like rheumatoid arthritis. That what it seems to do is prevent the progression of the late stage of inflammation. If you heard the previous presentation, I divided the disease into 2 phases. The first phase looks like the flu, acts like the flu, lasts about a week like the flu. But some patients, somewhere between 15 and 20%, seem to go on into this second phase where they get inflammation in their lungs and eventually inflammation in their entire body that leads to multi-organ failure and sometimes death. and certainly can require the need for support from a mechanical ventilator for a period of time. Clearly, the people at risk for this are those who have underlying disease and are older, but we can't, at the beginning of the disease, predict, other than risk stratifying based on these risk factors, that somebody is or isn't going to get this late stage of inflammation. Because this drug is currently in short supply, it has to be reserved for people at high risk of that late phase inflammation. It would be great if we could give it to everybody and shorten the course of illness and even potentially decrease the transmission rate. That would be wonderful, but this is not a drug that was used very often until now, and so the companies are revving up their supply, and it may be that over the next weeks to months, we will be able to expand the indication. Now, as a reflection of the effective leadership at Catalina Island Medical Center and the leadership that we received from our partners over at UC Irvine, from the very beginning, we started to request additional hydroxychloroquine even before it became widely known throughout the United States and the world that this was potentially an effective therapy. So we hope that we are in a position to be able to offer it to those who truly need it, because some hospitals aren't able to get any of it. And so we feel pretty good about the decision we made to go after that drug. Now, the other drug in the news is remdesivir, which was a drug that was originally developed for the Ebola outbreak a few years back. Now, Ebola is not seen commonly at this point anymore, and so this company wasn't making a lot of it and just happened to have some in supply. And so when it was tested in China, a little bit in Italy, and now in the United States, it seems to have some positive effect on patients who, again, are the most severe in the ICU, potentially looking at mechanical ventilation. But again, because it wasn't in production, because not a lot of patients needed it, it's in very short supply. And even though we requested it several weeks ahead of time before most hospitals realized this was a thing, we still haven't been able to get any of this, and that's been true of even the university hospitals over town. I don't know when that will change. And again, we feel good that we were out in front and were able to secure some of the hydroxychloroquine, but this is definitely not a situation where you should expect to receive a prescription unless you are admitted to the hospital and probably one of those high-risk patients looking at intensive care unit therapy. The main reason we decided to try and get a hold of some early on is because we anticipated that we could have difficulty transferring patients if hospitals on the mainland become overwhelmed, and that we may be stuck with ICU level patients that we really aren't equipped to take care of, and that in those situations the hydroxychloroquine may be useful to keep somebody prolonged until we can get them transfer. Definitely not anticipating that it would be something that we could use for anybody who tested positive or even had a suspicion. And the last thing I'll say about therapy is that it appears that Tylenol is a better choice than ibuprofen or naproxen. Ibuprofen goes under lots of names like Advil, and naproxen goes under Aleve. The physicians from France have said that they see worse outcomes for patients taking ibuprofen or naproxen, which normally are things that we would recommend for a flu-like illness. So it looks like Tylenol is your best bet to treat the fevers and the aches that would accompany this illness. Okay, so let me just go over briefly our approach. And again, it centers around the inability to get testing, period, and the inability to get rapid results, even when we do request tests. And so we're going to assume potentially positive cases, especially if the influenza and RSV tests are negative. Those patients we are going to sequester and really emphasize you need to not only sequester in your house, but within your house to stay away from other members of the household, particularly if they're in that vulnerable population. And we're going to monitor you. We're going to check in with you on a regular basis to track the progression of disease. If we're able to diagnose with confirmatory testing that there's positive result for coronavirus, that will be limited and targeting those vulnerable patients that are most likely to go on and progress to that secondary inflammatory syndrome, the acute respiratory distress syndrome or ARDS, because we want to watch those folks in particular to know when to intervene by bringing them into the hospital and starting to provide critical care, start to look for transfer over to the mainland, and potentially even use the medications that we mentioned previously. The one nice thing about the progression of disease is that for most patients it seems to progress over days, not hours, not minutes. And so we have the luxury, if you want to call it that, of checking in on a regular basis, giving very clear warning signs as to when you should call the hospital or return. And that way we can keep people in their homes who we know or suspect are coronavirus positive, and then make an educated decision as to who needs to come into the hospital so that we don't overwhelm our resources. And that way, whatever the limited therapy available, whether it's the medications or even things like the ventilators, the hospital beds, and the staff available, can be reserved for those who truly need it. Now, the way that we're going to approach testing is similar to what I presented a couple of days ago. And this is a more aggressive approach than what has been used in LA County by the Public Health Department. We are at this point testing with fever and some respiratory symptoms, and one of the following: the travel from the high-risk countries, and those ones are the ones that are on the news, but countries in Europe, particularly Italy, France, and Germany, China and other parts of Southeast Asia, and then parts of the Middle East like Iran. So travel from those countries, confirmed contact with a COVID positive or coronavirus positive patient, healthcare workers, because it's important to get them out of the front lines if we think they're infectious, or at least take precautions if we think that they might have been exposed. Then all it takes is suspicion of a positive patient or confirmation. And then this is where we're becoming more aggressive. We're going to try and test the high-risk population. And those include those of 65 and above with diabetes, with heart, lung, kidney disease, or some form of immunocompromised state. And that way we can start to monitor the patients within the community we think are at higher risk. We don't know if we're going to get the results back soon enough to even be able to use that in our clinical decision making. And so it may be that we're monitoring high-risk patients and that we have to bring them into the hospital still without confirmatory testing, just with a presumption that they're coronavirus positive based on the way that the disease is progressing. And we're prepared to do that. The other new thing is the idea that in certain situations, like a skilled nursing facility or assisted living, then we loosen the criteria, and it's not fever and respiratory symptoms, but fever or respiratory symptoms, because those are particularly vulnerable patients, not only for each individual, but because they're in close contact and have weakened immune systems, or at least that's what we assume, then the likely rate of spread is faster. So we loosen the criteria for those patients. And ultimately, a provider has to order it. There's not a situation where somebody can request it on their own. So these will be screened by one of the providers at the medical center. And the last piece is our role in this, where we really would like to be the public health entity in the community, because public health has not been prevalent, and we have some unique challenges and opportunities because of our geography. So what we'd like you to do is call the medical center before you come in whenever possible, because we are setting up to provide a system of questions and decisions that will allow us to serve you best and ideally keep people who are infected away from the hospital. That includes screening for coronavirus testing, and if that's the case, if somebody is deemed an appropriate candidate for screening, will arrange for you to be able to come and get tested and leave without having to enter the hospital, assuming that there aren't other clinical conditions that require us to bring you in or to evaluate you. We can arrange for appointments either in person, but we'll also be offering telemedicine appointments, which have gone exceedingly well. In fact, it wouldn't surprise me if people request to do this permanently, because it's nice to be able to chat with someone over the phone, and sometimes even use video conferencing and different forms of video servicing to do an entire appointment without having to bring you in to the medical center. At this point, it's for infection control, but ultimately it could be something just for convenience. We're going to be screening for what the optimal location of any sort of visit might be, and that could include the infection tent out where the ambulances drop patients off to the emergency department. We may decide to do the entire visit there to avoid contaminating the hospital or exposing people who may or may not be infected to the higher risk side of the hospital. If a patient is there for a non-infectious complaint, then that is the rationale for why we have designated part of the hospital as a regular or non-infectious emergency department, and as much as possible keeping infectious patients out of the clinic. We're going to explore different options and have already started providing community-based care, which includes not only calling patients and monitoring them, but potentially providing in-home care and protecting both the patients and the workers as best as possible. And so that could include something like monitoring the oxygen saturation of a patient who doesn't have results yet, or who didn't meet criteria for testing but are developing symptoms like shortness of breath and cough, where we just want to check the oxygenation. So it's very possible that we'd ask a patient to wash their hands and insert their hand through the door, check an oxygen saturation, provide some reassurance, and minimize contact both for the patient and for the provider. We'll be tracking the positive cases or the suspected cases, and then LEOS is even providing opportunities to deliver medications, again, to minimize the risks of leaving the house and coming into the pharmacy where there may be a higher concentration of patients who have other illnesses or potentially infectious diseases. So what I'm going to do now is answer some questions that have been submitted by you regarding testing specifically, but also regarding other things related to the coronavirus pandemic. And we hope that as this develops, that we can continue to be a resource so that you can ask questions, and we can provide answers to frequently asked questions online. We can provide updates as things change in the community and throughout the country and in the world. Okay, so now I'm going to read some of the questions that have been submitted. Some of these were answered, but I'll answer them again here. So, questions specific to the testing criteria for coronavirus or COVID-19 include what are the criteria, and I think I just spelled those out, but just to kind of summarize, we're taking a more aggressive stance in that not only are we requiring travel to a high-risk country or contact with a known coronavirus positive patient, but we're also going to test high-risk individuals who have fever and respiratory symptoms so that we can begin monitoring them and be able to detect any sort of deterioration, even potentially before we get test results back. So we can try and intervene earlier with either supportive therapy and potentially even including the use of medications. Are we currently testing for coronavirus? We are. We sent our first tests this week. We have not yet received the results, and we don't know what the turnaround is going to be. Our colleagues over in university hospitals with intensive care units say that sometimes it takes up to a week to get results back from a patient who is in the ICU, which is not particularly helpful clinically. And so again, we're defaulting to the idea that if you're negative for the flu, negative for RSV, and have the right symptoms, and if you are a high-risk patient, we're going to proceed with the assumption that you're positive and monitor you as if we knew you were positive even before we get the test results back. How many tests have been done? Only one has been sent over, and we drew another one and held on to it to see if there's a response to traditional antibiotics before sending it. And we don't know yet the results, so we don't have any positive results. The only other way that we would know about a positive result is if a patient was tested over town and then came over and told us. And if that's the case, which may well be a possibility, not because there's any more availability of testing over there, but for whatever reason, if somebody interfaced with the medical system on the mainland and found out that they were positive, that's something we would want to know, in part so we could monitor, and also for epidemiologic purposes to track others who may have come in contact with that person, because that would then put those patients in higher risk categories as being in contact with a known positive patient. What if someone tests positive? At this point, the likelihood is that we will already know whether they have progressed to that secondary inflammatory phase or whether they are recovering. So that's part of the frustration with the lack of testing, is that it's not particularly helpful for us making clinical decisions. But as testing becomes more available and the turnaround becomes faster, then again, we will emphasize, regardless of what's going on in the community with regard to sequestration, we'll emphasize to those people that they need to stay sequestered, and we'll begin to monitor them remotely so that we can bring them in, or at least go out and check oxygenation status if they seem to be progressing towards that secondary inflammatory phase. Will that person be transported off the island? Our ideal would be to transport patients over town as soon as they started showing indications that they may have entered that secondary or inflammatory phase. We're just not set up to be able to provide ICU level care, especially not for any long period of time. But if the hospitals over town are overwhelmed, then we may be stuck with patients that we otherwise would not want to be stuck with. And so we are ramping up our ICU level of care. We now have 3 working ventilators where we only had 1 previously, and we've requested several more. We've started training the staff who aren't necessarily used to taking care of ICU level patients in some of the basic principles, and the physicians are all emergency medicine trained and have experience taking care of critical care patients, and will certainly be involved in all of the decisions regarding critical care. We've begun to stock up on supplies, and that includes everything from the tubing that supply the ventilators to oxygen to other things that an ICU level patient would need, including monitoring type equipment and all the disposables that go along with taking care of an ICU patient. So that's where, again, I've been very impressed with how quickly Catalina Island Medical Center has responded, and even in talking to colleagues in other parts of the country who work for university hospitals, we've been much more aggressive at trying to secure what we fear could become necessary supplies in taking care of patients that otherwise really shouldn't be at Catalina Island Medical Center. And some general questions. The difference between coronavirus and COVID, I just want to make it clear. Coronavirus is the actual bug, that's the virus. The disease it causes is COVID, and it basically stands for corona, C-O, virus, V-I, disease, D, COVID. In 19 was the year that it first emerged. So we kind of blur the terms, but just so you know, COVID is the disease, coronavirus is the causative virus. Is there a cure for COVID-19? At this point, not yet. Are there medications or drugs to take to prevent? I think we talked about those. There have been some others that have been tried, including HIV medications that thus far haven't panned out. There was some interest in the idea that the coronavirus enters cells through the same receptor that we target for certain blood pressure medications, and that maybe those blood pressure medications would be protective. That really hasn't panned out. For those who follow the situation in China, they claim that their particular kind of soup might be protective, and actually did some clinical trials during their outbreak that suggested that that particular soup might be protective, and you can find recipes online. We don't know if that's correct or not. And then the last question has to do with vaccines, because there's been a lot of attention about vaccines, and this is where I may not know much more than you do in watching the news. I know that the first patients have been tested, and that the strategy that's being taken is to take people who have recovered from coronavirus and whom we assume are now immune to it, and look at their antibody levels against the virus and compare that to people who are receiving the vaccine. And that way, every person who receives the vaccine can be used as a subject to see if that vaccine is effective in producing the same antibodies that somebody who actually had coronavirus would produce. The opposite would be if you just vaccinated a bunch of people to see whether they got coronavirus. But because at this point the transmission rate is relatively low, we wouldn't necessarily have a final answer for several years to see if it actually protects you from getting the disease. So the hope is that if it's shown to be safe and if it produces antibodies that are similar to somebody who's recovered from coronavirus, that it will then be distributed into the community. And the closest or fastest estimates I've heard is by the end of the summer. Now, I think it will take a while to ramp up production, and so I suspect that the first people that will receive it will be the same people that we're talking about with regard to testing. Those will be high-risk patients, the elderly, people with comorbidities, and probably people in healthcare as well, if they haven't already received it, although one of the groups that seems to be contracting coronavirus the fastest is the healthcare worker. And then it will spread to the rest of the population. It would be fantastic if that happened before the next flu season. We're also hoping that the warmer weather attenuates or slows down the virus, even if it doesn't completely kill it. That's a pattern with some viruses like the annual influenza virus, but we just don't know at this point. We know it does still propagate in places that are right now in their summertime, like Australia, or in warm places like countries that are along the equator. So it's not completely destroyed by warm weather, but even if it slows a little bit, that may be enough to keep us from getting overwhelmed, and it may give us a little more time to develop that vaccine and protect us from the next wave. So I think that covers all the questions that were submitted. Hopefully you're finding these informational sessions useful, and perhaps this is something that will continue indefinitely even after the coronavirus has come and gone. Again, please engage with us. Please call when you have questions. Please go to the website and submit questions, and we'll do our best, make any suggestions that you have. And as new information becomes available, we'll try and share that with you as soon as possible. Thank you.